Okay, I want to talk about all the fun things that you can find in your urine. First of all, I'm going to start off with white blood cells. If you find 2 or more white blood cells in a urine sample on high power light microscope, then you would say this person has a high amount of white blood cells. They appear to be pretty large compared to other cells. They are multi-lobed and they appear granular in the urine specimen, and they can indicate that you'd have an infection or a contamination, especially if you have an associated inflammation or infection of the vagina or the urethral meatus of men and women. A lot of times that can be in a urine sample and contaminate it and make it look like you have an infection higher up in the urinary tract, but it's actually outside of it. So that's why you want to have a clean sample in order to properly test if there are white blood cells in the urine coming out. Next, I want to talk about renal tubular epithelial cells. So you have a small amount of those cells just come out normally, but if you have a high amount of those, that would be concerning and could indicate acute tubular necrosis because the tubes are just shedding those cells. And they appear larger than the granulocytes, and they have a round nucleus versus the low nucleus of the white blood cells. So these renal tubular epithelial cells, if they become laden with lipids in the tubes and they come out, like if you have lipiduria due to nephrotic syndrome, then you can get these epithelial cells that are called fat bodies because they're full of lipids. And we talked about that with nephrotic syndrome, the O. So these cells are known as the fat body cells, or oval fat bodies. And they'll have that Maltese cross look when you look at them under polarized light microscopy. And we talked about that already, but here's what they would look like. And next we're going to talk about casts. So hyaline casts, that can be normal in the urine, like 1 or 2, like spread out. But if you have a lot of them, then that's not common, and it can be they're made out of mucoproteins, most likely TAM horsefall proteins, which we know come from the thick ascending loop of the loop of Henle. But casts are only made in the like the collecting tubule, the distal part of the tubes in the nephron. So the cells would move to the collecting tubule where they make the cast and come out. And that's what the hyaline casts are made out of. They're pretty common, like I said, and they appear pale and slightly refractile. They're acellular, so you just see like a clear tube. Next is the waxy cast, and I think of like a candle made out of wax, waxy cast, because they appear tubular and cylindrical. They're highly refractive, so I think of like, you light a candle, it's light, so they're more rigid, like the hard wax, and if you find them, they're always pathological, and they indicate tubular injury, like in a more chronic level. If you find red blood cell casts, you would think glomerulonephritis, and it appears something like this. You'd have very malformed red blood cells in a cast, and you'd probably see other single red blood cells with it, not just the cast. And then white blood cell cast, you would also think glomerulonephritis, but most likely it would be acute pyelonephritis. And so that would be casts that look a lot like the red blood cell cast, except for they would be larger because the white blood cells are larger than the red blood cells. And if you suspect glomerulonephritis, you're going to want to do serological testing. So you'd want to do like an ANA complement, Hep B surface antigen, Hep C antibody, things like that to test to learn more about it. If you see a granular cast, which is just a tube, and you're just going to see tons of little dots in it, tons of little granules, and those are just degenerating cells in that tube, and that can also indicate acute tubular necrosis. So acute tubular necrosis can show these granular casts, and we already talked about another one that has acute tubular necrosis as indication, and that was the renal tubular epithelial cells. Next we can talk about crystals. So if you see a calcium oxalate dihydrate crystal, these are known as envelopes looking crystals, and those are when you don't excrete as much calcium oxalate dihydrate, and it's commonly found if you have short bowel syndrome, enteric hyperoxaluria, ethylene glycol, and acute renal failure is an association. The one that I've been tested on before is ethylene glycol, and we've just talked about that already with a wide anion gap metabolic acidosis. If someone's intoxicated with ethylene glycol, that will create these envelopes. So I think ethylene glycol, the E, and envelope-looking crystals. Next we have the triple ammonium phosphate crystals. And these ones are a little more elongated, and they're called coffin-shaped crystals, or like a coffin lid. And those are pretty common with a UTI, if it's caused by a urease producing bacteria. And they're also very common if you have an alkaline urine. So alkaline, think like a basic UTI, basic bacteria, coffin, because they're dead, I don't know, but triple ammonium. So next is the cysteine crystals, and those are rare, and we've talked about those already when we were talking about when things go wrong in the proximal tubule. So the cysteine crystals, they have this hexagonal shape, and they're clear when you look at them under a microscope. So you see them in cystinuria. Cystinuria, we already talked about, is an autosomal recessive inherited disorder where you have decreased cysteine absorption in the proximal tubule, and so that would accumulate and create crystals. Now we're going on to uric acid crystals. They can be normal if you have an acidic, a very acidic urine. They tend to form. And they're associated with uric acid stones and acute renal failure, so then it would not be normal. So they have different forms in the urine. They can have a rhomboid appearance or a needle-like appearance, and that's the uric acid crystals. Hematuria and proteinuria, I'm just going to touch on because there are other videos that we already talked about that. But hematuria is defined as having 3 red blood cells per high power magnification on 2 to 3 correctly collected samples of urine over a span of 2 to 3 weeks. And that would indicate hematuria microscopically versus if you see it grossly, you see the red pink urine. It might not be blood, it could be hemoglobin or myoglobin. So you have to look microscopically to see if it's actually hematuria. And then when you look at it microscopically, you can see if the red blood cells are shaped like normal red blood cells, nice and round, or if they're messed up and have like little loops and lobules in them. So that can indicate where the blood is coming from. If it's a glomerular problem, they're going to be really messed up because they're trying to squeeze through that glomerulus. And different things can lead to hematuria. Malignancy, you would think that in like older people, obstruction, infection, injury, etc. There's a lot of different reasons that somebody would have hematuria. And that can be kind of sifted through by your history and your physical. And then part of that history and physical, you're going to do some imaging. So you can do renal ultrasound, you can do intravenous pyelonography or IVP. A CT scan with or without contrast is the test of choice, and these would test the upper hematuria causes, and then the lower hematuria causes, you can do a cystoscopy or a urine cytology on morning voids 3 times, 3 morning voids, urine cytology. And so those are for the lower part. And then proteinuria, so normally you have less than 150 milligrams per 24-hour period of protein in your urine. So if you have more than that, you can be considered proteinuria, especially if there is a high amount of albumin. Another partly quantitative way to measure that is by dipstick, and it would be rated from a 1+ to a 4+ of protein. And that can indicate a large number of different kidney diseases. And nephrotic syndrome is the big one that has a large amount of protein in the urine. So now I'm going to get my little ladder and move it over here. So now I'm going to talk about renal failure, and we'll break it down into pre-renal, intrarenal, and post-renal. And those can be kind of sorted out with history and physical, different imaging, and different lab tests, and we'll go through all that. But just to break down the differences between the three a little bit, pre-renal failure is due to reduced perfusion to the kidneys. So you have like a low blood volume, so your kidneys aren't getting the circulation that they need. And if it's just short-lived, your kidneys can generally recover from that, and they won't have any anatomical or structural deficiencies. And that's just if it's short-term, but if it lasts for a long time, then your kidneys can shrink and necrose and die or be damaged and not be able to resume normal function. So it is a time-sensitive issue to fix. So with pre-renal failure, you would see concentrated urine because you don't have a lot of fluid going to it, obviously, and you wouldn't see a lot of protein or blood into it. With intrinsic renal failure, that's due to a lot of different mechanisms, parenchymal renal diseases, so like any of the other renal diseases we've talked about thus far. So the kidney is actually structurally damaged in this one, and when you fix the problem, it may or may not improve with time, depending on how bad the damage is and what it is that's causing it. The urine for intrinsic renal failure, so you'll have mid to moderate protein in the urine, and this a lot depends on what's causing the renal failure, but you'll have white blood cells, red blood cells, and pretty much any kind of cast, the hyaline, waxy, granular, brown, muddy, white blood cell. You can see casts in the intrinsic renal failure. For post-renal failure, a lot of times this is due to a lower urinary tract obstruction. It could be BPH, it could be something gynecological, different reasons. So if the obstruction is cleared rapidly, the kidney just rapidly goes back to a normal function. But if it's prolonged, it can cause damage to the kidney. The urine won't have any casts because it's after the nephron, it's after the collecting tubule, which is where the casts are made. And you won't see a lot of protein or sediment. The sediment may be bland in a post-renal failure. So like I said, you can kind of help weed through these and to see which kind it is by history and physical mostly. You can do lab tests and imaging, and the last resort would probably be biopsy. But for lab tests, a lot of times you look at the BUN or BUN and creatinine ratio. If you have a very large ratio, like greater than 20:1 BUN to creatinine, that would indicate a pre-renal because you would have a lot of BUN that's not getting filtered out. So it would be staying in the blood, so you'd have a really high BUN to creatinine ratio. If it's intrarenal, you would have less than 10% because the creatinine gets filtered out. So you'd have BUN to creatinine less than 10:1 for intrinsic renal failure. For post-renal failure, it could be anywhere in between those values. So it could be 10 to 20:1 BUN to creatinine. Creatinine is actually the most commonly used measurement of renal function because it's completely filtered out and excreted. It's not reabsorbed. It's inversely related to the renal function. So the more creatinine that you're excreting, if it's higher, then renal function is good. So just like a rough estimate would be 1 milligram per deciliter of creatinine, and then GFR would be at about 100. So 1 to 100 is very rough numbers if you're trying to estimate GFR. because you can use the creatinine levels to calculate GFR. 1 to 100 is like very rough.